Hi. Okay, I'm going to choose to think about how I'm talking at this late hour in the day as reinforcement for everything that you've heard already, because, of course, I'm going to end up probably saying some similar things to what some of my colleagues have talked about. But what I'm going to speak a little bit about some of the concepts that I think about when training students about working with substance use, and particularly about working with clients with substance use and histories of trauma. Okay, so I'm going to explore some of the application of the concept of harm reduction to treatment integration for substance misuse and traumatic stress. So what are some of the concepts that we wish to communicate when we are training clinicians to work with substance use, right? We've been kind of talking about some of that all day. But I think some of the first things that we're doing, and a lot of my career has been working with clinicians, who are early in their careers. But certainly I think one of the first things that we're often doing is, helping to challenge preconceived ideas, right? Many clinicians enter the treatment field with a number of preconceived ideas about substance use. And so one of our first tasks is to help students to recognize and reconsider some of their pre-existing attitudes and beliefs toward people who are using substances. Right? And as we've talked a little bit about today, right, these include some of those stigmatized and moralistic and devalued views of substance users, right? So, for example, that views of addiction are a function of weak moral character or a lack of willpower or personal choice. Like, those views are very present, even among clinicians at this point. And we certainly know, right, that unexamined stigma held by clinicians does subsequently influence treatment decisions and usually not positively. So from this vantage point, I like to think about starting with a discussion of the language that surrounds substance use, hoping to reduce some of the stigmatizing descriptors that have been entrenched in treatment culture, right, even including just moving away from the word addict, right, and toward something like perhaps people-first language when we talk about the idea of people who use substances as opposed to using the word addict. Right? But that can even be hard to absorb. It's surprising, right, to go through sometimes teaching this and then discover people come up to me right after class and they're still using the word addict. So a basic task is also to help students recognize that the role that psychologists and other mental health clinicians can play in the treatment of substance use, right? And that, I think, also is something that we've been talking about quite a bit today. But what we really want to promote is an approach to working with clients that includes compassion and openness and a willingness to be curious and flexible, right? So Debbie certainly talked about curiosity as a psychoanalytic concept, right? But more broadly, everything we do, right, from every vantage point is about helping people to become curious, right? Mentalization is about helping people to become curious about their own minds and the minds of other people, right? When we do, even from a cognitive behavioral standpoint, we're helping people to be curious about how they think about things and how those things come and integrate with, what they're feeling and the behaviors that they do. So we're constantly in a state of trying to help people be more curious about themselves. So I think being curious and flexible is really a highlight of what we're talking about today. Okay, so as I mentioned, right, a basic task, too, is just reminding students and sometimes a lot of people, right, that we have a lot to offer in the treatment of substance use disorders. And many psychologists still feel that treating substance misuse is not in their wheelhouse. And I think this is part of when we say talking about spread the word, right? It's trying to help people recognize that that is not the case, right? But that idea has been reinforced by separate treatments for mental health and substance use disorder, different modes of counseling over the years, and is still a bifurcated approach to treatment in many settings, right? Mental health counseling, substance use disorder counseling, right? They're different people in the same place, so they remain separate. And the disease model has also reinforced the belief that substance use disorder treatment does not belong in our backyard, right? It has focused on the medical side of recovery and fostered a very simplistic notion of treatment for substance misuse that fails to capture the complexity of what drives substance use disorders. I think Andrew this morning used reductionistic and anti-meaning as a way of describing the disease model, and I love that. It feels like it captures, some of the problems there. But we certainly know that problematic substance use is a complex issue. What else have we been talking about all day, right? And who better to address complexity than psychologists and other mental health providers, right? This is our bread and butter, right? We are talking about complexity of people all the time. And some of the other things I think that have come up today that are, describing like a complex concept, right? The idea of multiple meanings, right? That is complexity. When we talk about dissociated self states, that is about complexity, okay? When we talk about multiplicity of selves, that is about complexity, right? Trying to really understand all the different facets of who someone is, right? So Sarah, I think you talked about somebody in your group about the idea of a gem, right? And using that from a framework of mentalization, but I think it's also a nice way of thinking about a client, right? And all of the different facets that we have to consider when we're working with someone and understanding their use. So complexity is a natural bridge to harm reduction. Okay? And part of what we're helping students to recognize is that what initiates and maintains substance use is specific to each individual. The treatment is not one size fits all. That clients are in various stages of change in relationship to their use, and that we have so much to offer no matter what stage they're in. Right? And harm reduction is a vital component of this work. So especially for clients who are actively using and uninterested or unable to make changes to their substance use, right? As therapists, we can be a part of the process of helping clients to examine the impact of substance use on their lives and to begin to consider pathways toward change. So substance misuse as a complex biopsychosocial phenomenon, right? Or as Andrew puts it, a psychobiosocial phenomenon, right, has come to dominate our understanding of substance use disorders. And our teaching reflects the complex interactions, right, between the personal, the social, the contextual factors, right? So we can help students begin to recognize how many factors are at play, including the ecological system surrounding the client and their internal landscape, right, both psychological and biological. So this model helps students to integrate diverse contributions to substance misuse and begins to help them formulate their clients presenting concerns with complexity. So having a multifaceted understanding lays the foundation to meet clients where they are, right? So meeting clients where they are, a central tenet of harm reduction psychotherapy. Rather than impose our notions of what clients should be doing, right? We want to meet them where they are and try to understand how we can be helpful, right? By not creating demands for recovery, right? And in that way, we help to lower the barrier of entry to treatment. But meeting clients where they are also applies to trauma, right? So I think it's worth thinking about harm reduction from both a perspective of working with substance use and traumatic stress. So it's always interesting to me that many psychology students and clinicians, right, they're captivated by the idea of working with trauma. And yet most fail to consider how many traumatized individuals end up using substances, right? Usually as a means to manage feelings and symptoms, right? PTSD, anxiety, other negative feelings about themselves. Right? They become involved with substance use or other risky or addictive behavior. So traumatic stress response and substance use disorders go hand in hand. We know that at this point, right? We recognize the high rates of co-occurrence. Right? Especially for women in substance use treatment, for example, rates of lifetime trauma have been reported between 50 and 99%. Okay? And that if we think about current PTSD, For women, we're likely to see 1/3 to 2/3 with current PTSD in substance use settings, and for men, up to 1/3 report current PTSD. And PTSD, of course, like that's just one sliver of like how we understand diagnostically, like how somebody may present, as a consequence of having been traumatized at some point in their life, right? Or some of the more acute suffering from maltreatment that they may have experienced. So it is reasonable to assume that a significant number of clients with substance use disorders are impacted by past trauma. And moreover, among certain minoritized populations, high rates of racial trauma and discrimination are associated with high rates of substance misuse as well. So treating the ongoing impact of trauma includes attending to difficulties in the ability to regulate emotion, to take care of oneself, to manage relationships, to participate in the world, and to feel good about oneself. And these are some of the direct observations that parallel those of Ed Cancian, who wrote about the ego deficits that individuals self-medicate with substance use, right? Problems that are often derived from interpersonal trauma, right? So again, kind of affect regulation, self-esteem, interpersonal relationships, and self-care problems. And the relationship between substance use disorders and traumatic stress is also complex, right? As there are various pathways between the two. So substance use may be a response to a traumatic past, right? Or it could be a predecessor to the development of trauma. And there are also interactions between the two related to risk and susceptibility. So harm reduction, I think, lends itself to the treatment of both substance misuse and traumatic stress. And we want to help students to learn to consider, what is the best path forward for a client? How do we help students begin to think about that with their clients? Some of the same questions that we ask ourselves about a treatment approach for substance use are also relevant when there are traumatic stress symptoms. So individuals who are using substances and who've been traumatized can benefit from a harm reduction approach related to both their substance misuse and their traumatic stress symptoms. So what are some of the questions that we start with, right? Naturally, how do we best help this client, right? And what would the client like to work on first? So how many times today have we talked about the idea of this being a mutual process, right? This is a collaborative process between us and the client, and we naturally involve the client in the direction of care, right? This is what we're working on together. Clients have not always been provided with this opportunity, right, to help formulate their treatment. Some clients have done really poorly in treatment programs that demanded abstinence, right, that ignored the severity of their trauma symptoms. However, some clients cannot get clean or make changes in their substance use or stay clean, right, without attention to the traumatic past, right, and its relationship to their use of substances. So people have really been worried about the wrong thing, right? They've been worried about paying attention to trauma too early in recovery from substance use, right? The feeling for a long time is like we can't touch trauma. Person's too fragile. They're too early in their substance use, right? Clients will act out, drop out, or relapse. But a lot of clients dropped out of treatment because they didn't get to work on their trauma, right? So how much are we helping clients if we compel them to abstain from the substances that help them to manage, right, without providing them with the means and opportunity to address their traumatic stress symptoms? It is like pulling the rug out from underneath them. So how do we reduce distress and harm in someone's life, right? And can we be creative and flexible in helping clients to achieve their goals? Okay? And how can we respect and enhance the strengths that our clients have to recover? So for some time, we've been guided by the stage models of change and recovery, specifically the trans-theoretical model of change, Prochaska and DiClemente, and the stage model of recovery for traumatic stress by Judith Herman. And these models have emphasized the importance of recognizing the process of change and healing and acknowledging that change is not a lockstep or linear process. Okay? And also that what is good for one client may not be the same for another client. Yet, of course, many models assume a uniform recovery process, particularly abstinence-only programs. At the same time that we're attending to safety and stability, we also need to be careful and not to underestimate clients' capacity, right? We do not want to fragilize our clients too much, okay? Particularly when it comes to engaging clients in past-focused trauma work. Some of our clients recover most effectively from problematic substance use when they have directly addressed their traumatic memories. So with past-focused trauma treatments, for example, clients begin to articulate the unspeakable harms they have experienced, and by processing through these experiences, some of the pain and the shame and the blame that they have taken on for themselves derived from the trauma are often reduced, enabling the client to consider changes to their use of substances. Right? So don't underestimate or fragilize the client, right? We need to think about what is right for an individual client. Okay, so again, the stage model of recovery from Judith Herman has been the dominant model for a long time, right? And it has suggested an approach that progresses from one stage to the next, although not necessarily linearly. Even Judith Herman kind of acknowledged that. Right, but from this standpoint, we would establish safety and stabilization first, right? Enhance management of symptoms and improve functioning. Then we would move on to a processing phase and work through and integrate traumatic memories. And then we would continue to help the person to integrate traumatic experience and consolidate their treatment gains and kind of pursue personal growth. And from this standpoint, right, once clients demonstrate stability in some of the areas mentioned, the stage-oriented approach would suggest that clients are better prepared at that point to engage in therapeutic work that addresses their trauma. So some of the first-line targeted strategies that have been identified over time and verified in some research, right, include emotion regulation strategies, anxiety and stress management, cognitive restructuring, and interpersonal skills. So the stage model is essentially a harm reduction strategy, right? But it has in part been born out of fear, right? Particularly if clients are using or have used substances. Again, will clients act out, drop out, relapse? What's interesting is that clear superiority of a stage-based approach that emphasizes stabilization first has not been empirically demonstrated. Okay? Nor have studies consistently shown that individuals who misuse substances cannot tolerate treatments that address trauma while they're actively using. Right? So what we have learned is that, in fact, clients can do some of these things that we have been fearful about over time. So not everyone is ready to approach their traumatic past without some stability in other areas of their life, right? But yet many are and can. So the worries that treatment providers have had that addressing trauma will exacerbate substance use or derail sobriety have largely been shown to be unwarranted. We once worried that we could not even talk about trauma with our clients who were using substances because they were too vulnerable. And indeed, some clients do need increased stabilization before addressing the emotional intensity of past trauma, right? So don't get me wrong, I understand that that is often the case. But we now know that some clients can talk about trauma and even process through traumatic memories, often without an extensive stabilization first, to work before they work on their substance misuse. A stabilization phase for some clients may be unnecessary. And in fact, that if we are fragilizing our clients by insisting on stabilization, right, clients may actually be delayed from receiving effective trauma treatments. So in fact, some studies have demonstrated that emotion regulation, potentially a sequela of early traumatization, and something that we usually think about doing first, right? We tend to emotion regulation first, right? Is actually improved following trauma-focused treatment, right? So once we address some of the PTSD and some of those traumatic stress symptoms, right, people start to downregulate. Some of those hyperarousal symptoms go away. Okay, so I want to think about like the ways in which a harm reduction plan, right, can include treatment for traumatic stress or substance misuse, right, one for the other. When it comes to integrated treatment for trauma and substance misuse, a harm reduction approach is not one size fits all either, right? But it can be helpful to think about how harm reduction in one area can benefit the other. So trauma treatment is part of a harm reduction plan for substance use, right, or substance misuse, if it helps clients to begin to manage and reduce their distress, right? So we treat the traumatic stress, right? We reduce and manage somebody's distress, right? And clients are then sometimes able to use more safely and or use less. Treatment for substance use is part of a harm reduction plan for traumatic stress, right? If it helps to stabilize clients and then enables clients to approach trauma, perhaps in a way that they weren't able to previously. Okay, so I want to also reflect on other ways that we're being challenged to consider harm reduction. And some of you are going to say, that's crazy pants, right? This is something I would joke with with one of my clients who would use that phrase when she felt like I was saying something that was absurd. But can using substances actually be an effective harm reduction strategy for traumatic stress? Okay? So can using substances actually be an effective harm reduction strategy for traumatic stress? Okay? And this runs counter to many of the things that we've been talking about, of course, right? Because the self-medication hypothesis suggests that people are seeking to reduce harm from trauma through the use of substances. And that most of the time, if they're presenting to treatment, right, they've seen their lives deteriorate, something has really gone terribly, awry, right? This strategy has gone wildly wrong. Okay? While effective in the short run, most of the time, right, like the substance use becomes problematic over time and takes on a life of its own. And this is, of course, the crux of someone's problematic use. Okay? So it's a controversial notion, but what if for some clients, reducing the harm or distress derived from their trauma may mean ongoing use? So I'm primarily speaking about cannabis. And as the landscape around cannabis has changed, right, we find many people are able to use cannabis reasonably to manage emotional distress. And what if cannabis is the best option, or at least a very good option, for a client who's hypervigilant or anxious and who has not had good experience with other pharmacotherapy options, right, to help downregulate? Some of our clients have been telling us this for years. But we have had less freedom to condone or maybe even encourage responsible and moderate use of substances, such as cannabis, to help clients to moderate their hyperarousal. So I want to present a case. This is a fictional case, just to talk a little bit about this concept. So Miss C is a cisgender, straight-identifying woman from an affluent background. Her mother was chronically depressed for periods of her life, leading to periods of emotional neglect, and she was also physically abusive. Ms. Z was sexually abused by a cousin periodically throughout childhood as well. And in the profound experience of abandonment and confusion and shame over these experiences, Ms. Z did not share about the episodes of abuse. Even her father remained unaware of what was happening at home. Ms. Z struggled to feel good about herself and to connect to others, and she was alternately numb and dissociated and fearful much of the time. In middle school, when she began to hear peers talk about substances, she was intrigued and excited, right? She could not wait to see how these things would make her feel. And she began to try anything that came her way. Cannabis was an easy and calming option. By high school, opioids were unparalleled in the pleasure and release she felt, and this habit spiraled quickly. Her family became aware of the extent of her substance use when alerted by a friend of Miss Z's from college. Her family had the resources to support her recovery and encourage treatment. Okay? And while there were fits and starts, right, it was not a smooth process. Ms. Z was not always, willing to go along with this. Ultimately, she became sober from all substances after a series of traditional abstinence-based programs. Although she'd been on buprenorphine, she did not remain on medication-assisted treatments, but she continued in therapy for many years, continuing to process through the maltreatment and the abuse she had experienced. During this period, she experienced episodes of acute depression with suicidal ideation, and she had very limited relief from antidepressant SSRIs. Past-focused trauma treatments, including narrative work, were helpful to Ms. Z in reducing some of her re-experiencing and hyperarousal traumatic stress symptoms, but she continued to struggle with feelings of isolation and low self-worth and persistent irritability and hyperarousal. And she continuously felt that she was just like white-knuckling it through her days, right? Everything was so stressful, okay? So Ms. Z tentatively began to talk about the idea of returning to cannabis use. She was fearful about bringing this to the attention of her therapist, afraid to face the condemnation that she had felt in the past when she had picked up any substances and violated her sobriety, so to speak. Ms. Z was surprised to find that her therapist was open to talking about the benefit that she felt she would derive from cannabis, notably improved ability to sleep and relaxation. Within a harm reduction framework, Ms. Z and her therapist talked about the potential benefits and the risks of returning to cannabis use after many years of sobriety. Ms. Z felt great relief at being able to talk about this in treatment and confided that she had already begun to smoke weed and had been finding it helpful. But the guilt and self-recrimination around picking up that Ms. Z had felt receded. And importantly, Ms. Z felt no urges or cravings to return to opioid use. Cannabis helped Ms. Z to sleep, but also enabled her to re-engage with the world. She primarily smoked at the end of the day, after work, or on weekends with friends, and she began to feel less isolated and depressed. She continued to use responsibly, not using in dangerous situations or using in a way that interfered with her professional and personal responsibilities. So Ms. Z also began to feel more at ease in treatment, having found that she could experience her therapist not as an adversary around sobriety, but as an ally. This also allowed the therapy to deepen, allowing Ms. Z to begin to explore additional elements of her traumatic past that she had not been able to when she had still been less trusting of her therapist. Other conversations also opened up about the possibility of considering some of the novel pharmacotherapies for depression and PTSD. Ms. Z had wondered about the possibility of ketamine to further help with her depression and psychedelics to help with some of her persistent traumatic stress response. Ms. Z and her therapist agreed to remain open to these possibilities as they became available, but to continue to weigh the risks and potential benefits of these options. And they also agreed to pay close attention to her cannabis use for any signs that it might become problematic or lead to her feeling cravings and urges toward more dangerous use. Okay, so in this example, right, Cannabis really helped Ms. Z to stop white-knuckling it through her days, right? After having had limited relief from other kinds of pharmacotherapy, so to speak, right? Traditional medications had not been that helpful for her. It improved her sleep better than traditional pharmaceuticals, okay? And it helped Ms. Z to be less isolated and less depressed. And for the first time in years, Ms. Z began to experience a sense of relaxation and even joy, which was shocking to her, shocking. So it also created a more trusting relationship with her therapist within a harm reduction framework, okay? And it enabled her to deepen the therapeutic relationship. And this made it easier to continue some of the work related to past maltreatment and trauma. So in summary, I presented that example, right, just as a way of kind of emphasizing that we're talking about complexity and flexibility and how important that is to and also just readjust how we would think about things, right? Like if I had thought, I would not have thought in a million years, 20 years ago probably, that I would be talking about cannabis this way, and talking with clients this way about the possibility of using cannabis effectively and taking it off the table, so to speak, as something problematic if it wasn't actually problematic, right? But I think, right, like there are a lot of examples, like, of ways that we have to kind of go outside of like the normal way we might consider, like, okay, how do we help someone, and is there, are we taking it too far, right? So there is this sense, right, from Teresa's work that Brian talked about in the morning, right, of making room, right, for us to be able to consider different things, right, as opposed to enabling. Right? And one of the examples I love from Denning and Little is a story that they tell about a group experience where someone in the group, right, I think this was a drop-in group, and someone like maybe was intoxicated but fell asleep in the middle of the group, right? And there was this question of like, oh my God, what do we do with this person? And what the clinician did was to actually just kind of take off her coat and walk over and put it on top of the person who was sleeping, and making room for that person and their needs in the room, right? Slightly different, but I think the similar kind of concept, right? So we're trying to encourage people to really think, be flexible, like in their approach to this work. So we're teaching and training clinicians. We want to model and encourage flexibility. We're not throwing caution to the wind, right? Of course, and taking a harm reduction approach. But rather allowing for a range of options that best suit the client, okay? And allowing for ways in which those needs might change. We can use some of the stage models for guidance, but also acknowledging that they're just a guide, right, to be modified and needed to meet the unique and complex needs of our clients. And I hope maybe some of my current students and past students who are here today can testify, right, that if they absorb these messages, right, we hope that they'll be on their way to being sensitive and compassionate and responsive clinicians. Thank you.